Also served on expert panels, collaborating on the development of the best practice guidelines for assessment and managing of stage 1 to 4 pressure ulcers and screening for dementia, delirium, and depression in older persons. Welcome, Kevin and Antoni.
Hello, good morning, everyone. I didn't know that I have such a long introduction there. But anyway, it's great for me to present to you some data that we have worked together today in terms of looking at the analyses of claims and costs related to long-term care pressure ulcers. And I think we'll talk a little bit, sort of present some of the background information, especially with the recent change in funding policy, looking at the reduction in the high-intensity fund utilization and the whole change in the per diem for wound care, the 0.63 cents that we have to manage wounds in terms of prevention and management. And I think Tony have lots of data to share with you today in terms of whether it actually makes sense and how do we sort of get around looking at prevention and management differently by looking at resource utilization. We'll come up with some recommendation in the end. And of course, we used a number of databases for the analyses, and we used the chronic care data, and I have access to the ISIS data with the whole big database, and actually Tony used some of the data from IntelliHealth that we able to merge some of the information together to validate that a lot of those information do actually make sense. It's not just one database or just one group of data that actually help us to validate the finding that we have to share with you today. And of course, the research team, Tony is the key person for this presentation in terms of looking at some of the cost data that he'll be sharing with you later on today. And myself and also Corinne McIsaac. Corinne is a researcher in Nova Scotia. She's actually going to join us a little bit later on today. She's presenting in Nova Scotia right now with some wound care data to the government, looking at changing the funding policy as well. So what we're trying to do is really by looking at the data, the intent objective is to look at how we can inform the government and policymakers in terms of the cost and the intensity of care and resources required to manage pressure ulcers or chronic wounds better in long-term care facilities. I'm getting over a cold, so if my voice sounds kind of nasal, you have to forgive me. And of course, you and I know that in long-term care, in any facilities, it's very difficult to control in terms of what kind of wounds is going to get into the facility. And that's one of the challenges that long-term care facilities have to face constantly, especially when you have individuals that require hospitalization transferred out into acute care, into emergency, and we always have this blaming game, right? So it's all because of the fact they went to long-term or to acute care, to emergency. They come back with some kind of pressure ulcers or chronic wounds or skin tears for that matter. So I think the challenge that the long-term care facilities face right now is the lack of control in terms of the prevalence of chronic wounds. So when the government trying to say, well, we're going to allocate a certain amount of resources for you, and looking at benchmarking the chronic wound issues, sometimes it may not be so fair because it depends on the type of patients you get admitted into your facility, the complexity of patient, and the type of patients that may be at risk for developing pressure ulcers and other type of chronic wounds. And we know that the biggest predictor of new wound is previous ulcers, and even for residents with stage 1 to 2 pressure ulcers or admission, they're at higher risk for developing pressure ulcers in the end. So I think the key message is, and we have more slides to show you that in terms of how we utilize resources right now, the focus is still on the treatment, the management of existing pressure ulcers or chronic wounds, especially some of the deeper ulcers. So the question is whether there should be a shifting of focus on the preventative measures. And how do we come up with those resources? And when we look at the different resource utilization groups, the RUG groups, and 50% of pressure ulcers of those residents fall in the 4 RUG groups. and collectively account for less than 10% of assessment. And because of the stage 3 and stage 4 pressure ulcers, there are few numbers of them. So they dilute the whole effect in terms of how it influence the RUG categorization. But we know that with in terms of the management of pressure ulcers and chronic wounds, it ranges from $74, $88 to about $106.63 per day, per resident per day. So I think a lot of the resources being utilized on the actual patient resident care by RNs and RPNs and PSWs. And we have a slide to show you in terms of the distribution of time that people actually utilize to provide care for individuals with chronic. And I think the other challenge with the management of chronic wound is the fact that all CMI, the case mix index, assumes non-staff time costs are constant across the RUG groups, but this is not always the case, and that's part of our challenge to try to inform the government and the funding body in terms of the resource we need to manage and prevent pressure ulcers better. And of course, right now we have a lot of different types of resources and dressings and topical treatment that may be able to change the way that we practice. For example, some of the foam dressing and some of the more advanced modern dressing doesn't require daily dressing change, but you can change it once a week or 2 times a week. But because sometimes the way the funding is being offered to long-term care, they don't always take into account of the actual cost. So you may end up with doing a daily dry dressing, but the staff time is actually more intensive than doing a 2 times foam dressing change when you can reduce the daily requirement for the dressing change. I think that makes sense from a clinical perspective. So I think we just have to generate some good data to inform the government. And this is a good slide to show you the number of interventions. We look at section M and describing the different types of interventions that are being put in place for the management of chronic wounds. And there's good news and bad news, I think. The good news is you can look at the number of different types of interventions. I think most long-term care facilities are adherent to best practices, meaning they do turn patients, they do have therapeutic services. Mind you, this data is acquired before the change in the high-intensity funding. So I think it will be interesting to come back in a couple of years' time when you only have 63 cents plus the nursing care envelope funding to really manage the care of this group, this cohort of patients, to see if we can continue to provide pressure relieving devices and provide nutrition, hydration intervention, and at the same percentage, at the same rate. And the other thing, I think the other important point here is there is high intensity, high resources, a huge number of interventions being put in place for deep pressure ulcers, stage 4, stage 3 pressure ulcers, versus the stage 1 and for people who are just at risk for developing pressure ulcers and who did not have a pressure ulcer yet. And that's why you see the p-values in terms of highlighting that there's a huge difference comparing the 2 groups. And I guess the question is, why do we have to wait until the pressure ulcers are stage 3 and stage 4 to implement those interventions? And then is there a way to really revert this picture so we're actually implementing more interventions in stage 1 and stage 2, or even for at-risk individuals from a preventative perspective? And I think there's a lot of good studies done indicating the importance of turning. And this is a study or a review paper by OTAC looking at systematically all the literature around turning. And actually, there's a number of good studies published in the last couple of years. Cochrane has a very good review paper. And the turn study has just been completed and published as well. The turn study is funded by the Ministry of Health and also the Theta Group, the Toronto Health Evaluation Economic Assessment Group. right around University of Toronto. So what they were able to validate is the fact that you don't actually have to turn patients or residents necessarily every 2 hourly. If you have a therapeutic service, you can just turn individuals every 4 hourly to achieve the similar outcomes. And the amount of resources and money you can actually save from the intervention is quite significant, and I'm not quite sure you can see the small print there. In the study, they compare people who were being turned 4 hourly on a therapeutic service as opposed to people who were being turned 2 to 3 hourly on the regular mattress. And they're able to demonstrate that there were about 47% reduction in the pressure ulcer development in the treatment group, and the treatment group is the one that has the mattress with the 4-hour turning schedule. So I think that, again, that go back to some of the messaging that we're trying to emphasize here is the preventative measure. We need the actual operational cost to get better devices, better mattresses, better nursing care, better training in order to provide care, not just about managing the actual stage 3 and stage 4 pressure ulcers. And looking at the nursing time, again, when you look at the time required to manage from stage 1 to stage 4 pressure ulcers, including some of the deep tissue injury and stageable wounds. And of course, with the stage 4, you have on average 8.7 minutes versus stage 1, 5.5 minutes. And when you compare to what is being funded by the government, and it's actually just 7.8 minutes for residents with stage 1 pressure ulcer. And actually, those time that the people spend on providing care consume 25 to 50% of the total nursing time. So I think that's really significant in terms of what nurses are doing in long-term care and how they're doing what they're doing the best to prevent and manage pressure ulcers. And that may not be enough to keep the prevalence and incidence rate down. And those are the distribution of pressure ulcers by different RUC groups, and definitely you can see pressure ulcers in all different RUC groups and 34 RUC groups. The highest number in those RUC groups is the 16 SEC and so on and so forth. But the message, I think the information we want to emphasize in this slide is the fact that there is it requires a lot of time to provide care. And this is a study done by the Canadian Staff Time and Resource Utilization or Intensity Validation Study. They actually followed nurses and looking at calculate the amount of time required to provide care for individuals with pressure ulcers. And those are the average time that required to do that, and separate them into the RPN groups and the RN group. I think the key message is I'm not quite sure the funding right now is actually addressing the high intensity required, the nursing time required to provide adequate care and appropriate care for this cohort of individuals with pressure ulcers. And definitely, I think just another sort of reiteration of the resources required to manage different types of pressure ulcers. No surprises there. With the stage 4 and stage 3 pressure ulcers, it requires more resources, more nursing time and stuff. And again, in terms of the treatment, the length of stay, the duration of wound care time as well, definitely much longer for a deeper pressure ulcer. So again, going back to the messaging around preventative measures, how do we prevent some of the stage 3 and stage 4 pressure ulcers? And starting from looking at the stage 1 and stage 2 and the people who are at risk for developing pressure ulcers. And just to give you a snapshot in terms of the type of chronic wounds out there in long-term care facilities, I think this is probably a little bit of underestimation because the data is as good as people's documentation, right? As you and I know that sometimes documentation is not perfect. Of course. So, and we look at the skin tears, 6% compared to, I think, some of the literature, I think Karen can attest to that some study done looking at 20% residents in long-term care facilities actually have skin tear. So this is probably underestimation here. And then looking at some of the pressure ulcers, you can see the stage 3 and stage 4, the numbers are quite low. And that's why all together drive all the CMI and the whole rug group, the intensity down. But when you look at them individually, they do require a lot of resources and staff time to manage them well. So, and pass it on to Tony to tell you more about some of the cost issue and the analyses.
Thank you. Masterfully done. Thanks. So I'll talk to you about the analysis that was done primarily from the IntelliHealth database to look at prevalence. Now, the couple of points first. The data that you've just seen was from Corinne McIsaac's database, the Health Outcomes Worldwide database, which captures primarily in Nova Scotia, but also in Ontario, which captures point of care staff time and products used on an encounter basis. So much more granular, much more detailed data than is available through the RUG's MDS type of data. Couple of shout outs also. We listed all the older important people at the front, but the people that did a lot of the work were at the OLTCA offices. In particular, Tim Cheng and Tommy Wong did a lot of the analysis as well. They're not here to take credit for the work they've done. The analysis here is based on intake assessments, as you know from the RUGS data, from the MDS databases, and then the quarterly assessments that are done. So, as you can imagine, the ability to track on a daily basis the progress of wounds and the healing of wounds, etc., is somewhat compromised, as is the fact that wounds are not individually identified. The total number of wounds is captured, for instance. So we try to infer here, not from relatively small numbers of cases, 200, 300, 400, as is done with the health outcomes data, which is much more granular, but from tens of thousands of cases, but at a much more high level. I thought I'd present the work that was done by John Hurdy's team developing the pressure ulcer risk scale from the MDS data. Initially, because it was very instructive to me as a way to get into the analysis of these data, and I think there are some instructive lessons from it. Is anybody here not familiar with the PERS scale? So you're all familiar. So just as a quick recap, mainly to remind myself probably, the way this was developed was to essentially try to take the Braden scale, try to map the individual items in the Braden, the domains in the Braden, back to items that are captured in the MDS, and then to tweak it a little bit, add a few more factors which were thought to be clinically important, and then use some statistical machinery to try to squeeze out of that the most important items, and in this case there were 7 items that could then be aggregated into an index as a predictor of, in this case, pressure ulcers that were incident at the time of admission. So these were only admission assessments. Sorry, not present at the time of admission, but developed by the first 90-day assessment. So what they did was they took the cohort of patients that were admitted over the course of about a year, and teased out of that the 90+%, 91 or 92% of patients that didn't have a pressure ulcer at intake, and then followed them into their first quarterly assessment, and those that had developed, and then looked at the percentage that developed a new ulcer, and tried to look at the intake risk assessments, or the intake factors, to see what percentages developed ulcers amongst that group. What's instructive here is that you typically get this. I'm going to move away from the microphone. You typically get this reverse monotonicity. You get the vast majority of people are at low risk, and the relatively small number of people at low risk are at much higher risk of developing pressure ulcers. That's very instructive from both a clinical and an epidemiological perspective, and I think that sort of dogs the whole policy approach and the clinical approach to approaching prevention. The more that you focus your prevention at those that are deemed to be highest risk, the more cases that you're going to actually miss, because the majority of cases occur in people at low risk because there are so many more of them. So although individually they're at lower risk of developing ulcers, the total number of people at low risk swamps the overall high risk folks in terms of the numbers of people with that at risk categories that develop ulcers. That suggests that a risk mediated approach to prevention of ulcers is ultimately going to have not be very efficient. It'll be efficient for the few people that you've identified that are high risk and that you've taken preventive measures, but you're going to miss most of the incident ulcers. And that would suggest this is very similar to population versus high risk strategies for lowering heart attack rates, for instance. Do you do more good by modifying the diet of a population, or do you do more good by putting statins and other preventive medications into the regimen of high-risk individuals? The population approach always wins. So from the perspective of where you invest in terms of preventing, in this case, skin ulcers, but in many conditions that can be, for which there is some kind of a risk gradient, the population-based approach is relevant, and that would suggest that prevention practices ought to be thought of across all incoming patients and all resident patients. The second point here is that this scale was built looking at trying to replicate the domains of the Braden score. It was found in a small subsample of patients where they actually had clinically measured the Braden score and used these administrative data that their performance characteristics were equivalent. If you take it one step beyond that and say, well, what can the data actually tell us if we don't fix ourselves on looking only at the Braden scale? It turns out that two of the MDS items, the ability of a patient to transfer themselves and the requirement for support in transfer, those two factors alone have as much predictive power as the PERS scale, and therefore equivalently as the Braden scale does. Kind of makes sense because one is essentially a behavioral or a functional measure as opposed to a more static measure that's incorporated into the Braden. But what it suggests is that the ability to predict ulcers is not fixed on any single subset of items. You don't have to slavishly look only at certain items. You can probably get an intuitive sense and the data show us this, just by looking at whether a patient can transfer out of bed and how much help they need transferring. That in itself captures as much prediction as a 7-point PERS scale does. And secondly, that you can't really do better. We've gone through virtually the entire MDS database to try to find out if there's any other combinations of other factors that hadn't been looked at, and you can't really beat this. So the ability to predict it looks impressive. There's a tenfold difference between those at low and those at high risk. But again, that means that even if you incorporate all of your prevention strategies in those at the highest risks, let's say the 5, 6s, and 7, and that's maybe 7% of your population, you're going to only have if you did nothing, if you just did usual care as opposed to improved care, the percentage of patients that would develop an ulcer within the first 90 days is well under 1 in 6. It's well under 15% in the 5, 6, 7s, and 8s there. whereas the vast majority of ulcers will occur in those that you didn't direct the high-risk strategies to. That was a long-winded way of getting at one slide of work that I haven't done. But I think there are some very important. Did I press that twice? I don't think so. Okay, so back to what we got from our data. In terms of patients being admitted to long-term care, what the PERS study did was, I think, reflect an implicit view, and that's that ulcers occur within long-term care. By not looking at the admission of patients with pre-existing ulcers, it said nothing about those. So if we go back and look at the data and go back to that initial cohort on assessment, we actually can find that more than 10% of patients are admitted with a pressure ulcer. And 3/4 of those are in stage 2 or more. When one looks at it in this more dynamic sense and accounts for the fact that people are coming into long-term care with pre-existing pressure ulcers and then tracks what happens over time, the story is a little bit different. It's a little bit different than saying, can we predict new ulcers in long-term care? It becomes, overall, is there a net gain or loss in terms of numbers of ulcers, i.e. are more being healed than are occurring? And what we can see is whether we look at stage 2 or more or the more complex stage 3s and 4s, there's roughly a 35% reduction in ulcers over the course of the first year, which means that there are more that come in with ulcers than that are existing with ulcers at year 1. From year 1 on, the prevalence of ulcers on quarterly assessments is roughly constant. So the analysis that we did was what's called an Inception cohort. We basically tried to find a very clean cohort or clean data set, starting with patients that were admitted. So that meant that patients had been admitted before the time period that we were looking at, starting 2009, weren't included in the analysis. And so patients with very long stay patients in long-term care with prevalent ulcers were not included in these data. The reason that we did an Inception cohort analysis was it gave us a better idea of the dynamics of how many people are coming in with ulcers, how many people have ulcers healed during the course of their initial year and a half, how many people are developing new ulcers that didn't have ulcers before, what's the transition between stages, how many get better, how many get worse, how many stay roughly the same. The importance of looking at it from that perspective is if one wants to prospectively look at potential funding approaches, any kind of funding that's done by a payer is going to be dependent on new cases. They're going to essentially be negotiating about whether or not there should be a change in funding for patients that are admitted with ulcers, for which there was obviously no ability of the long-term care home to prevent the ulcers, versus ongoing payments for either prevention or absorption of costs for ulcers that developed during the course of a stay. These are the numbers shown graphically in terms of the prevalence using that Inception cohort. So we start everybody at time 0. These are the percentages of different kinds of ulcers. You can see that the most common reported is stage 2. Stage 3s and 4s, the more complex ulcers, are each at around 1.5% at admission. And there's a gradual decline over the first year in terms of the overall prevalence. Beyond a year, the quarterly prevalences stay constant, as you can see in the numbers here. So the take-home message here is the story is actually a little bit different than is usually portrayed. It's not that ulcers occur so much in long-term care. It's that there's a relatively steady rate of healing as opposed to development of new ulcers. That's relatively in an equilibrium after the first year of admission. And during the first year, there's a third less ulcers at the end of that year than there were at admission. This is a graph showing the variation in admitted ulcers by home. So we can, using the analysis of risk factors for prevalence, the prevalence of ulcers at admission, we can predict for any home, given the case mix of patients that come in, how many we would expect to have come in with a pressure ulcer. You can see for many homes that is anywhere between 0 and 6 ulcers, or for all homes, it's between 0 and 6 ulcers for stage 3 and 4 ulcers. Remember, that's roughly only 1% of ulcers. When we look at the actual numbers of patients that are admitted with these ulcers, you can see that there's a wide variation around the expectations. So a home might expect, in the middle of that range, might expect to only have 2 new stage 3 or 4 ulcers coming in. Remember, these are not developing during the course of a stay. These are patients that are being admitted into the home based on the risk factor mix. But you can see that each of these dots represents an Ontario long-term care home, that those numbers can range anywhere between under 1 and over 5. These are very expensive conditions, obviously, to treat. And so any kind of, the point here for me, the take-home point, is any kind of funding approach which takes the risk of having an ulcer at admission and incorporates that into any kind of a funding envelope that comes with the patient at admission. Let's say there was a separate funding stream for the first year of care, would be not a wise way to go. Obviously, homes above the line would be at their detriment, and homes below the line would be essentially getting a windfall for funding because they didn't take those patients in. You can imagine also the practical implications in terms of the willingness of homes to take in patients with known ulcers if there was any kind of a funding that was based on prospective rather than actual funding. So that's the variability. This is a slide that shows just how variable the case mix is. So even if we try predicting incident stage 3 and 4 ulcers, or that are incident at admission. They're prevalent before they come in, but when they come in, they're incident. The case mix, so by home size, and I've sized homes here by the average annual number of admissions, you can see that the case mix of the different kinds of patients that are brought in by different homes is relatively variable, so that you would expect quite different numbers of pressure ulcers even at admission. So if you combine those two variabilities, how variable is it in terms of the expectation of how many ulcers you get given the size of the home, and then how many you actually get given how many you expected? That shows that there's a huge variability in terms of the annual intake of complex ulcers into long-term care by homes. Obviously, in any kind of situation where costs come in large quanta, in large blocks of cost associated with individual patients, and here we're thinking of patients being admitted with stage 3 or 4 ulcers. Smaller homes, given the fact that they may be expecting less than one of those cases per year, if they're hit with 2 cases, that's a big proportional size of their nursing and supply costs load on those costs. Larger homes, they can adapt to variations somewhat more because they'll have more of a cushion to deal with it. So, what's the bottom line from in terms of recommendations? Individual. So I'm struggling here a bit because I've given you the message that prevention needs to be thought of across the board. I think the implication is we don't throw away high-risk strategies or we don't meld them across the entire population. What we have to look at is that everybody's at risk. Some are at higher risk than others. And the allocation of funding and the allocation of resources to prevention should encompass all patients, but those at higher risk obviously will require higher degrees of resources. Now, whether or not it's cost effective to incorporate the pressure relieving surfaces for all patients as opposed to high risk patients, I think is the kind of analysis that needs to be done in terms of cost effectiveness. My sense is, what's the life of one of those mattresses? Does anybody know?
Max 5 years.
Okay. Well, we were looking at a payback with the high-risk patients of 1 year. So that would suggest that it would be interesting actually to do analysis and see whether there would be a payback over 5 years given the occurrence of ulcers across the population. In terms of funding approaches, I think this is probably the one that's the most obvious. We've seen from this analysis that more patients are admitted to long-term care with pre-existing complex ulcers than are in long-term care at 1 year with complex ulcers. Obviously, there's absolutely nothing a home can do to prevent the admission to prevent an ulcer, except perversely to not admit the patient with an ulcer. So, and I'd be very interested to hear from you, the practitioners, how you approach this. Obviously, there's a disincentive to admitting a patient with a pre-existing ulcer, given the fact that what we've seen in the analysis so far shows that the funding for the care of these patients is essentially underfunded. The potential for disincentives for admitting patients with complex ulcers that into long-term care, let's say transferred from acute care, would be ameliorated by a funding approach which recognized that homes are taking in complex patients and recognizing probably that in the first year that those costs are going to be higher as the healing rates come down to the equilibrium. And as was said earlier, there's always a slide that says there should be further research. I think the focus here would be on a number of things. One is the case costing of, I think more than just wound care, but in this case, since we're talking about wound care, the case costing of these complex and clinically important therapies needs to be done much more in a much more detailed fashion, so that we're not trying to infer from quarterly data and from very small costing databases what the actual costs are. I think I'll leave it at that. I think we're at the end here.